A good morning to you, and I'm delighted to join in this Hong Kong SRS chapter meeting this morning, and I'd like to thank Jason Ho for inviting me. So I'd like to talk about dose differences according to planning philosophy today. And what do we mean by that? Well, the dose delivered with SRS is affected by the definition of the target coverage and selectivity, the prescription isodose and heterogeneity within the target, dose calculation algorithms, and radiobiology. So we'll start with definition of the target. We tend to define the target typically on T1 weighted MRI images, but also T2. And these are subject to the partial volume effect, as is CT. So that's dependent on the voxel size, the contrast enhancement, and windowing. So let's look at a brief example. On the left we have T1 weighted MR images, in the middle we have T2 weighted MR images, and then on the right we have CT. And this is a intracanalicular vestibular schwannoma here. And you can see that the contour on the left looks appropriate. It looks a little bit too generous when compared with the T2 weighted image, and it looks too generous compared with the CT. And you'll notice that we've got extreme saturation of the windowing on the T1 weighted image here and on the CT. And if we re-window those, then we get something that we can now see is maybe a little bit too generous on the T1, still looks too generous on the T2, and potentially too generous on the CT. So we can then re-volume this with these unsaturated windows, and that actually resulted in an 18% reduction in target volume just by re-windowing. Your MRI is absolutely critical. On the left we have a 1.5T scanner. The images are fairly reasonable. On the right we have a 3T scan with multi-channel head coils, and we've picked out a very small met in the cerebellar vermis there that you would not pick up on the 1.5T scan. It even makes a difference depending on what contrast agents you use. So on the left we have Multihance, on the right we have Gadovist, and we always tend to use Gadovist for planning multiple metastases because it increases the conspicuity of the lesions and even the number of lesions that we detect. So target definition depends on the imaging sequences used, the windowing, the slice thickness, the contrast agents and concentration used, and on the user itself. Here are some other examples of what we might use. So time delay makes a difference, and in this paper published in JNS, we saw lesions that were not apparent if the MR sequence was acquired immediately after injection, but then after 10 minutes and 15 minutes we start to see a lesion. So typically we wait about 20 minutes after contrast injection when we're imaging patients with multiple metastases. And here's another example with a lesion in the cerebellum which was not apparent at 0 minutes, but certainly was at 10 and 15 minutes. Even the slice thickness makes a difference. And this was a study that I was delighted to be involved with the group from MD Anderson. I thought this was pretty obvious, but I remember going to a centre and encouraging them to reduce their slice thickness from 3 millimeters to something a bit lower, and the radiologist kicked back and said there's no peer-reviewed evidence that it makes a difference. But in this study we certainly showed that. We had 28 patients harbouring 102 metastases. They were imaged with 1 millimeter thick slices, but then those scans were resampled at 2 millimeters and 3 millimeters, and the same two oncologists were asked to contour all of those patient scans over a period of weeks so that they forgot the original contouring. And here we see an example of a metastasis that is apparent on the 1 millimeter slices but not on the 2 and 3. So we detected 102 lesions with the 1mm slices, 3% of them were missed at 2mm and 13% were missed at 3mm. But interestingly here you can see that the mean volume of the metastases increased dramatically, particularly with the 3mm thick slices. So that's because you get an enhancement of the partial volume effect, and that will increase the apparent volume of your target. Here's another example where actually a blood vessel seen on the 1mm slices was misinterpreted as a metastasis on the 2 and 3mm slices. So let's look at target coverage now, and a bit of background. I was trained at the Karolinska around 25 years ago, and their philosophy was, particularly for benign targets, you should cover 95% of the outline target was enough, and that minimizes the amount of normal tissue irradiated, and 5% of the target that's outside of the prescription isodose will receive a dose that's very close to the prescription isodose, so that's okay. So they also said you don't need to treat 100% of a benign tumour to get local control. And then at the same time, the other influential SRS centre was in Pittsburgh. They said you don't need to even outline the target. You cover all of the target with the prescription isodose, but interestingly, retrospective outlining has shown that maybe 97 to 98% coverage is typical for moderate-sized targets, although it is 100% for malignant disease. And there does seem to be this difference in philosophy. I've called it oncological versus neurosurgical. So if I work with neurosurgeons, they'll say, well, benign disease doesn't need total removal, so partial treatment may be fine. If we leave a little remnant of a vestibular schwannoma on one of the cranial nerves, it tends not to grow back. So in the same way with SRS, we can have a similar philosophy. So subtotal coverage is fine, while the oncological philosophy tends to be that every tumour cell needs to receive the prescription dose. And that's where margins come into play. The contouring can make a huge difference. So here we're seeing a pituitary adenoma in the coronal plane with a contour that's been reconstructed from axial contours. And what we see here is an inconsistency from one contour to the next. And that produces, some people call it a Christmas tree type effect, or a spiky contour. If we were contouring the tumour in this plane, we would not contour in this way. But what you can see here is we're covering this with 15 gray, but actually it effectively looks like we're adding a margin, and that's because we're covering 100% of the target. We're covering all of those little spikes that are probably just small wobbles on the mouse when this contour was created. And so that effectively increases the volume that we end up treating. And here in an example, it's the same metastasis treated with a single collimator isocenter with the Gamma knife. On the left, we've got 90% coverage, then 95, then 100% coverage, and then on the far right, 1 millimeter margin. And these are all treatment coverages that I've seen when I've visited and audited centers around the world. And yet there's actually a difference of 48% in the dose between the 90% coverage and the 1 millimeter coverage lesion. And that's 48%, not just to the maximum dose, but everywhere else as well. Yet we're still getting the same prescription dose. So all of these centers would actually report the same prescription dose to the target, even though there's a 48% difference. Here's a series of 9 vestibular schwannomas that I saw in a department that I audited quite a while ago. All of these were reported as receiving 12 gray. But if we look at the percentage coverage of the targets, they're all quite different. They vary between 94% coverage and 100% coverage. Now, if we look at a parameter that's maybe more objective, let's say the dose to 95% of the target volume, we can see that this varies dramatically. So we have one case, case 7, where the dose to 95% is 11.5 gray. So that's less than 12 gray. And yet we have another one where the dose is 15.2 gray to 95%. So this is inconsistency just because the percentage coverage hasn't been clearly defined. And of course, when we're treating with SRS, we have a very high dose gradient that's both outside and inside the target. So adding a margin will effectively treat the target to a higher dose. The prescription isodose is also important because this affects the internal dose gradient and the maximum dose within the target. So if we treat with a low prescription isodose, maybe that's good if we're treating malignant disease where we want to have a high dose to hypoxic areas. But it affects the mean dose, the integral dose, and higher prescription isodoses tend to decrease the dose gradient outside the target. And there have been a number of references, Linac and CyberKnife, showing that if you lower your prescription isodose, you actually improve the dose gradient outside of the target. Here's a recent one where they looked at 30 patients. These were treated with HyperArc, single brain mets. They had 6 plans that varied between the 80% isodose all the way down to the 33% isodose. And what they found in this was as they decreased the prescription isodose, they actually improved the dose gradient outside of the target and lowered the 12 gray volume, but they increased the dose inside the target. So to me, that appears to be a win-win. Radiobiology is also something we should be interested in because sublethal repair during a prolonged treatment, that's anything from 5 minutes and above, reduces the biological effective dose of that treatment that's delivered. So treatment is from the first isocenter, beam, node, arc, or dwell position to the last. And we've shown that in cell survival studies. So here we've got an example of a 99.999% cell kill, which we can achieve with 26 gray delivered acutely. So that's in a period of 5 minutes. But we need to increase that to 35 gray and that's a 35% increase if we deliver that same dose over 120 minutes. And with a paper from BJR, from Bleddyn Jones and John Hopewell, we're now able to calculate the variation in BED. So these are some patients I was involved in treating, vestibular schwannomas to 13 gray, and you can see the huge range depending on how long the treatment takes to deliver. But this does apply to both Gamma Knife, CyberKnife, and stereotactic Linac. And what we can see here is a histogram of different 851 vestibular schwannoma treatments, with the Gamma Knife and CyberKnife treatments tending to be on the left between a BED of about 44 and 65. And then the Linac treatments tend to be much higher than that because they treat patients in a much shorter amount of time, and if you add a margin, you'll increase the BED even further. So you can see a huge variation there. So just to summarize, these are the planned versus what I call delivered variables. So we've got variation in the prescription dose definition, the target definition, the calculation algorithm, which I haven't touched upon, and the biological effective dose. And if we sum those in quadrature, we're talking about a 45% difference in dose, even though we might report the dose in exactly the same way. And this is without accommodating for margins. So to summarize, there are many subtleties in the treatment that are often overlooked. We cannot use doses published by other groups unless we understand their definition of target and dose. And only by recording more treatment parameters and publishing these with results can we learn more. I'd like to thank you very much for your attention and your kind invite today.